Afternoon, good evening, everyone, and welcome to today's webinar, Barriers to Migrant Care in Sub-Saharan Africa. This webinar is a collaborative effort between Migrant Outreach and the Association of Migrant Disorders. And first of all, I want to say thank you to everyone that joined early and to our panelists on the call. So we're grateful to have everyone join us from different parts of Africa and beyond. So thank you once again for joining, especially to the early joiners. So to start with, as you may know, migraine remains one of the most disabling conditions globally, and yet it continues to be misunderstood, underdiagnosed, and undertreated, especially in low-resource settings like Sub-Saharan Africa, where we live. Today, we bring together experts from across the region in Sub-Saharan Africa and also in the United States to share insights, identify roadblocks, and propose practical solutions to improve migrant care. Thank you again for joining us. And towards the end of today's conversation and discussion, we will be reserving time for Q&A. So, should in case in the point of at any point during the panel conversation you have any question, please feel free to use the Q&A box, and I will try to get to as many as possible. So, as a point of introduction, my name is Olarinde Akiwumi. I'm a pharmacist based in Abuja, Nigeria. I'm the founder of Migraine Outreach. So I'll be moderating today's session, and I'll be doing that alone. I also like my co-moderator to also introduce himself also very briefly.
So I'll just say my name's Frederick Godley. I'm a otologist in Rhode Island, United States, and I work with Olarinde in my role as president of the Association of Migraine Disorders. And thank you for all the panelists joining us today.
Okay, so without taking so much time, before we dive straight into the panel discussion for the sake of time, we also first like to introduce our panelists representing different regions of Sub-Saharan Africa, from Western Africa to Southern Africa to Central Africa, and also from the United States. So first, from Rwanda, we have Dr. Elena Dagnachiudo Yulma. She had a medical degree from Aramaya University and also specialized training in clinical neurology from Addis Ababa University. She also served as past president of Association of Ethiopian Neurologists. Currently, she is an assistant professor at King Faisal Hospital in Rwanda. Thank you, Dr. Yulma, for joining us, and we can't wait to have conversations with you. From Nigeria, we have Dr. Gerald Onweguzie. He is an associate professor of neurology and lecturer at the College of Health Sciences, University of Abuja, Nigeria. He is also an honorary lecturer at the Department of Human Physiology, University of Abuja, an honorary consultant neurologist at University of Abuja Teaching Hospital. He is serving currently as the secretary of the Nigerian Headache Society. You're welcome, Dr. Gerald. From Zambia, we have Dr. Diana Cielo. She is a neuroinfectious disease specialist. She trained at the Johns Hopkins University School of Medicine. She is an associate professor of neurology at the University of North Carolina School of Medicine. Currently, she's living full-time and also serving as the director of the first and only neurology postgraduate training program in Zambia. You're welcome, Dr. Cielo. So for the last but not the least speaker, I would like for my co-moderator, Dr. Goli, to introduce her briefly. Thank you.
This is Chia Chung Cheng, a fellowship-trained neurologist both in headache medicine and vascular neurology. She had her early training in Taiwan, followed by neurology residency in the Mayo Clinic in Arizona, and her vascular neurology fellowship was at the University of California in San Diego. She's done her headache fellowship at the Mayo Clinic in Arizona, And she is currently, as we've mentioned, working out of the Mayo Clinic in Arizona. She has a particular interest in AI research. Maybe she's performed AI research at the Stanford Human Artificial Intelligence Institute, and she's currently professor of neurology at Mayo Clinic in Arizona. Thank you for joining us.
Thank you, Dr. Gurley, for the introduction, and welcome, Dr. Chang.
We'll be moving straight into the panel conversation, and today we'll be touching on few key themes around migraine care, from diagnosis to treatment to misconceptions around migraine, stigma, education, awareness, and also opportunities for improved care and training, where each panelist will be sharing what is actually obtainable in their region and setting. So the first thing we'll be looking at is diagnosis, and I would actually like for Dr. Yilma to go first in this round of question. So Dr. Yilma, you can unmute. How common is it for migraine? Yes, can you hear me?
Yes, I can. Yeah.
Okay, great. So Dr. Yilma, how common is it for migraine to be misdiagnosed or undiagnosed in your setting? What are the most frequent misdiagnoses you've encountered for patients who have migraine?
Okay. So migraine headache is one of the conditions that have a high burden in sub-Saharan Africa, with a lot of misdiagnosis, and there are four multifactorial reasons. One of it being a shortage of specialist neurologists around the region. So I had a privilege of working in both Rwanda and Ethiopia. So I have seen a variety of cases that were labeled to be other things, for example, hypertensive headaches, tension headache, even patients being labeled as just trying to get out of work because they were complaining headache repeatedly. So it is a common illness, that is a common disorder that is being misdiagnosed among patients, usually even from a referral from a primary health setting to reach to a neurologist. It takes a very protracted period of time, and especially in female patients, they tend to be overlooked, and their symptoms being attributed to overworking, being stressed, and so on. So it is a common disease to be misdiagnosed, and I see a lot of patients who are undiagnosed even for a very prolonged period of time, being given an acute headache disorder, and later on being placed on opioids or paracetamol and so on for just brief headache control, later on developing even medication overuse headache. So there is no specific large studies that are done to show the exact percentage or the exact number of patients, but it is one of the commonest outpatient department visits disease, especially for neurology-based clinics and even outside of those. So it is a common disease to be misdiagnosed. So the common misdiagnoses, like I have mentioned, include hypertensive headache and tension-related headaches. So in both, there are some studies done in Ethiopia, back home in Ethiopia, where they try to see what kind of headache is common, not just in a hospital setting, but in factories and so on. So majority of the patients are diagnosed as having tension headache or being overworked and so on. But I tried to see reports from Minister of Health from Rwanda, whether there is reports of cases seen at outpatient departments, especially at the teaching university hospitals in the capital city. It shows that it's at least number one or number two cause of outpatient department visits. But majority of the patients reach to these neurology centers because of the shortage of neurologists, significantly delayed, and it's usually detected after a large disease burden has occurred on patient.
Thank you, Dr. Ilima, for the insight and perspective. We would like Dr. Gerald to also share the his own perspective based on his own setting and also from his own experience and practice. Hello, Dr. Gerald.
Yeah, good evening, everyone. Thank you for allowing me to participate in this discussion. Um, well, a migraine headache is a very common, relatively common headache in our environment, of course, but misdiagnosis remains a big challenge. Basically, in our own setting, most of the severe headaches patients present to you and say, I have migraine. The patients, in fact, tell you I have migraine. And when they mean I have migraine, it means that the headache is severe. So the severity determines the terminology that is used. So once patients come in and say, I have migraine headache, you don't need to argue with them. You say, okay, tell me how this migraine headache is going on, or what's happening about your migraine headache, or what are the presentations. So typically they will tell you themselves that they already have migraine. So the duty, therefore, of the clinician is to unravel whether the patient truly presents with migraine, is actually presenting with migraine or not. So misdiagnosis already, the patient already misdiagnosed him or herself, and of course, he's just waiting for a confirmation from the clinician. You know, so when the clinician sees, of course, it's either to follow that, pursue that direction and say that truly you have migraine or you don't have migraine. So already patients have predetermined mind that they already have migraine based on their severity. So if the headache is mild, of course, migraine is out of the question. They don't believe they have migraine. The other thing about migraine headache in our own setting is in Africa here we have, or Nigeria rather, we have a lot of malaria and enteric fever. So most headaches are attributed to either malaria or enteric fever, which is popularly called typhoid fever. So a lot of our headaches are also misdiagnosed in that direction, and the patients are repeatedly treated for malaria probably on a monthly basis, or 2 weekly or 3 weekly basis, or even for enteric fever. So most of the time they say, oh, my enteric fever is not going, my malaria isn't going. And so the issue of migraine does not even come in. For those who already think that they have migraine, which is already of course misdiagnosed by them already because of the severity of the headache, then that's another class. The second class of misdiagnosis is the malaria enteric fever, what I'll call complex, where people are repeatedly treated for a febrile illness repeatedly because they have a headache, not undergoing proper review by a neurologist. Of course, there's limitation of neurologists in our own settings. So a lot of patients go through the general practitioner, and sometimes because of the impression already that the patient has that already I have malaria, my malaria is not going to go, my enteric fever is not going to go, then of course the clinicians follow that line, pursue that line, and they continue to have repeated tests. And of course, we're in an endemic region, so malaria parasites more often are not to be seen in the blood, maybe 1+, 2+, as the case may be. And of course, they get repeated treatment. Question in mind, example typically is, my daughter is on a migraine, by the way. I am a migraine myself, and then even my daughter and my son. In my daughter's secondary school, until it came to my understanding, she was repeatedly treated for malaria. In fact, almost on a monthly or 3 weekly basis, she got anti-malaria. Finally, I had to go to the school, speak to the nurse, the nurse assistant in the school, who I told clearly that this is what my daughter suffers from, and I gave her her migraine pills, and that's brought an end. So she gets treated for malaria maybe once or twice a year. If not before then, she was getting treatment almost on a 3 weekly basis. So the big challenge we have here is the misdiagnosis is towards more of febrile illnesses, like I said, malaria and enteric fever, and that poses a big challenge because almost all headaches are either malaria or enteric fever. We don't have so much problem like my predecessor spoke about headaches related to migraine. We don't have, hypertensive headaches are not so common in our own setting, but more of migraine. Of course, tension type headaches are not misdiagnosis that we see in our environment. Tension types are commoner, but of course they don't present typically early. But the ones that will present to you can be misdiagnosed as migraine. Because, of course, when the headaches are getting severe for the tension type headaches, they now present to the hospital after a couple of months or weeks or years, and they present, and in fact, they normally insist, but like I said, based on the severity, that I have migraine. So just play along with them in that direction. Medication overuse headache is also a very big challenge here for migraine because of the misdiagnosis. In fact, I saw a professor who was on Medix 55 just like 2-3 days ago. Medix is a combination of paracetamol, caffeine, and Nurofen, sumatriptan, and yet the headache was not resolving, and he was so worried. And he's had this headache for several years, but he told me recently it has worsened to a point where he cannot even give lectures anymore because he couldn't tolerate sound at all. Sound was a big problem for him. So before he serious, and I explained to him that already he's already that, because he takes these pills almost every day. So he falls into the category of medication overuse headaches, in addition to the primary headache disorder of migraine, which was diagnosed for him. I think I'll stop here at this point in time. Thank you.
Thank you, Dr. Gerald, for your insight you shared. So we'd also like to move on to Dr. Saylor.
Sure. Thanks, everyone. I think in Zambia, we have some similarities to both settings. I would say the biggest problem for our patients with migraine is just not realizing that headache is a problem and that it's a problem that can be treated. So, a lot of the patients who make it to me have never even tried a paracetamol or an aspirin or any sort of NSAID, and have just said, oh, I've always just been told to drink water and it will go away. And so I think there's a huge lack of awareness both amongst primary healthcare workers and the general public that headaches are a disorder and that there are effective treatments available. So I think that's the first problem. The second problem, similar to East Africa, is that when patients do present to clinics for headaches, they are usually told they're due to hypertension. And these are not patients that are having a hypertensive crisis. They're patients who are just chronically hypertensive. And, it's estimated that 50% of adults over 30 in sub-Saharan Africa have hypertension. So it is quite common for these two disorders to coexist. And so they're often just labeled as hypertensive headaches. And then they're given medicine to treat their hypertension, but that doesn't help their headaches. And so I think that's the second problem. And then in the more educated urban population, we also see a lot of self-diagnosis similar to Nigeria, and a lot of people ending up with medication overuse headaches. And so that, I think, is just easier access to over-the-counter pain medications in the urban setting. And so that's the other end of the spectrum that we encounter as well.
Thank you, Dr. Saylor, for sharing your insights. To Dr. Chiang, would you like to comment on the points raised so far? I know your practice is quite different from what is obtained in Sub-Saharan Africa. Hello, Dr. Chiang.
Yes, first of all, yes, thank you so much for inviting me to join this excellent panel discussion. I'm very honored to be here today. So to answer this question, how common is it for migraine to be misdiagnosed or underdiagnosed? I think in the United States, as we all know, in the world, migraine is extremely common. In the US specifically, migraine is affecting 16% of people in America, which is about 39 million. In my practice at Mayo Clinic, and also across the US, migraine is very common for migraine to be misdiagnosed or underdiagnosed. In fact, there are large epidemiology studies, such as the Overcome study or Cameo studies, that suggest that in the US, only about 60% of patients with migraine, they have received a migraine diagnosis. That means about 40% of patients with migraine, they have never received a migraine diagnosis, which is a lot, and then we can do better for that. For the second question, what are the most frequent misdiagnoses I've encountered? I think a lot of them with migraine were misdiagnosed as sinus headache or allergy-related headache. A lot of patients were diagnosed with tension-type headache as well. So I think personally in my practice, sinus headache, tension-type headache, allergy-related headache are the most common misdiagnoses that I've encountered.
If I could also just add to that one of the things that, and you can correct me, Dr. Chang, if I'm misrepresenting this, but when patients ask me about having a headache and the cause, I usually just try to find out if there's another part of the nervous system that's involved. So by diagnosis, obviously, you would have light or sound sensitivity, but also GI reactions. And so to me, the distinction between, let's say, a malarial effect or perhaps a tension headache would be that another part of the nervous system is irritated and not functioning properly, which helps pick up a lot of patients who have where the headaches are maybe not as intense, that they're self-diagnosing. And the other sort of adage that I use, and again, I may be overstepping, but I prescribe to the theory that with each headache is really like an epileptic fit. Let's say you're having a neuroinflammatory storm, basically, in your nervous system. And so I try to get my patients to treat each of the headaches as they're coming along. Don't wait. And you may be wrong a few times, but it's better to err on the side of overtreating them sometimes, as long as you're not encouraging somebody to use the same medication over and over. I again, am not suggesting that we go down the road of overuse headaches, but rather using a lot of different strategies to treat each headache as they go along, hopefully preventing progression to a more chronic form.
Yeah, I agree that what Dr. Goldley brought up was very important in terms of distinguishing between infection, like malaria-related headache, versus like a primary headache disorder. It's important to first rule out other secondary headache. If there's evidence of infection, then we need to treat the infection. Regarding your question about tension type headache versus migraine, there's typically I go with the ICHD criteria, as you have mentioned. Migraine is typically pulsatile, unilateral, moderate to severe, aggravated with activity. They only need to meet 2 out of the 4 of those major criteria, but there has to be one of these accompanying symptoms, including photophobia or phonophobia, nausea, phonophobia and photophobia, nausea or vomiting. So they need to have one of these associated symptoms. And the headache need to be moderate to severe, versus tension type headache is typically bilateral. The headache is typically mild. So the symptom is a little bit different regarding migraine and tension type headache, as you pointed out. You also brought up another important point of treating early, and I certainly agree with you. It's important for patients to treat their migraine early, because like the triptans and other medications are always more effective when patients take it early at the onset of headache. But I always remind patients not to overuse these medications and limit it to 3 days per week, which is about 10 days per month.
And I'm going to make one final comment and then let the other panelists have a crack at this. But I would also, as an otolaryngologist, we see a lot of patients with migraine who do not actually meet the criteria of ICHD-3. ICHD-3 is a very strict definition that is extremely helpful for research, so that you have a very clear understanding who you're treating. But migraine, as you all probably know, but I'm just saying for the sake of our audience, is a pretty sloppy, ill-defined illness of our nervous system. And so there's a lot of variations of migraine. They don't always meet that ICHD-3 criteria, which is why I was emphasizing sort of just this more being thoughtful about it affecting other parts of the nervous system. So, and I'll just say as a moderator, we all need to keep our responses relatively short. So I'll try to not say so much.
Okay, thank you, Dr. Chang. So still on diagnosis, and as Dr. Golly rightly said, I think because we still have quite a number of questions, we can actually keep responses brief, so we can actually run through all within the time we have. So briefly, do you have any personal experiences where a misdiagnosis or delayed diagnosis has adversely affected patient care or their perception of their illness? If there is, please share. So would have loved to start with Dr. Yilma, but I think our network is a little unstable at the moment. So Dr. Gerald, if you can go first.
I think I've already shared something already, but I can still just repeat some of the few things I said. I mentioned about my daughter who was repeatedly treated for malaria, and I had to intervene in the school by letting them know that she's a migraine one, and give them the medication for prophylaxis, because she didn't tell me she was having repeated headaches. Of course, being in school with the stress of going to classes and then going to prep and then reading after classes. She's in college. That takes a lot of that gives her a lot of stress and pressure, and then she needs to read late nights, and that triggers headaches. So she was repeatedly treated for malaria, and like I said, is a common problem here in Nigeria, where people are treated repeatedly for malaria as opposed to proper diagnosis for migraine headaches. I think I will stop at this. Thank you.
Thank you, Dr. Gerald. Let's move straight to Dr. Saylor.
Thanks. I don't think I have a specific patient, but just in general, I think every time you kind of undo a diagnosis that someone has been treated for incorrectly, it undermines confidence in the healthcare system and the healthcare workers in general. And so I think it does do, while they're happy to, have a good treatment and have relief, I think oftentimes there's a lot of frustration at the suffering they endured from a misdiagnosis and questioning that. And so I do think it has impacts not only on people's health, but also how they perceive the healthcare system in general.
Yeah, thanks for that particular insight, how the patient themselves perceive the healthcare system. Dr. Yilma, please confirm you can hear me.
Yes, I can.
Yes, please, over to you now to this response and your previous thoughts.
Okay, so my previous thought was one of the things that a common reason for a misdiagnosis of migraine is also sinusitis. Also, for the personal experiences for misdiagnosis or delay, I had an encounter with a patient who had a chance to attend a PhD program abroad. But when he reached there, because of the workload and so on, he started having recurrent frequent headaches, and he started overusing medication. And then the headache became very difficult to control, resulting in him withdrawing from his academic activity, resulting in significant disability in his life. He was a PhD student. He stopped attending classes. Then he had to do even manual work because he was not able to tolerate the light in classroom and in offices. So the way his headache was initially thought because of the stress of the work, it is significantly affecting him. So I see a lot of patients who are significant delay in treatment. Plus, patients tend to come saying that I have a migraine headache, but on top of that, they will think that everyone is getting the diagnosis of migraine, especially if they're from an urban community, and deciding they don't actually have a migraine and deciding to delay their treatment. So these are common scenarios that I see, and I have seen a significant disability in patients, and that's what I have.
Thank you, Dr. Yilma, for your response. Yeah, we'll be moving to the next thing, which is stigma and sociocultural perception. And this time around, we'll be starting with Dr. Saylor. How is migraine perceived in your community, and are you aware of people with migraine being stigmatized?
These are great questions. I'm not sure that I would say there's stigma around it as much as just misunderstanding. So, as I mentioned, a lot of people don't realize that migraine or primary headaches or headaches in general are a primary medical disorder that can be treated. And so that impacts their decision to seek care, but it also means that the people around them may not be understanding when they have a severe headache and they're unable to do their regular duties. And so I think there's just maybe a minimization of the severity of the problem, but I don't think that I've seen patients with migraine stigmatized in the same way that we do patients with like overt physical disability or epilepsy in our setting.
Thank you, Dr. Salo. Dr. Yilma, do you think individuals with migraine in your settings are stigmatized?
So it might be because I have worked in both countries in the capital city, where majority of the patients are quite educated. But like Dr. Salo have said, I don't usually see a stigma against primary headache disorders like epilepsy and so on. But it usually is perceived as it's just a headache, and that notion will make patients feel the severity on their own rather than getting the assistance, for example, from their employers, from family members, and so on. I see that, but stigma is not a common thing. So it's usually minimizing the symptom patients have, even if the headache is disabling. Patients tend to be overlooked. That's the thing, yes, usually, but stigma is not a common thing for primary headache.
Thank you, Dr. Yilma. Dr. Gerald, do you also share in this perspective?
Like most of the speakers have spoken, stigma is not so much of a major issue in migraine. But the only comment I want to add in here is that headaches are sometimes trivialized. I think that's a big problem. Headaches are sometimes trivialized. They don't see headache as a disease. They just assume it's just only headache and it's just a pain, and then you should be able to bear with it and live with it and so on and so forth. So accessibility of care is an issue because they don't even think the headache is a problem. That's the only thing I'm going to add in terms of sociocultural perception of the migraine headache. But in terms of stigma, I don't think it's an issue. So usually, like I will say, the headaches are sometimes trivialized by those who are non-sufferers. So the people who don't have the headaches don't really appreciate what migraine is all about. They don't understand the seriousness of the headache. It's rather trivialized, But in terms of the patients particularly being stigmatized. So, for example, someone in migraine has a severe headache and says, I need an XQCT. The clinician might say, it's just a headache. Why do you need an XQCT for it? Just a headache. You couldn't go to work with a headache. Is that a problem? Why do you want to leave your work because of a headache? So I think it's a little bit trivialized. I think that's just what I'm going to say.
Thank you, Dr. Gerald. Dr. Chang, please, do you want to share what is actually obtainable based on what the other panelists have also shared earlier?
Yes, of course. So migraine, we wanted to emphasize as a medical community, and recently more and more medical doctors and providers understand that migraine is actually a very complex neurological disorder that can be extremely debilitating. However, previously there has been, or even now currently as well, there has been a lot of stigma associated with migraine. So for example, as a lot of the panelists have mentioned that people think migraine is just a headache, when indeed migraine is associated with a lot of debilitating symptoms such as cognitive dysfunction, like annoyed sensitivity, GI dysfunction. There are other types of stigma. For example, people might think migraine are like a psychological disorder, when indeed it is a complex neurological disorder. Around school or workplace, there are also stigma in the workplace. For example, people might think that patients with migraine or people with migraine are less trustable or there's less credibility, or there's associated with gender bias as well. They think that migraine is all related to hormonal and women being a little bit more weak. And there's social stigma as well. Like people feel like there's guilt associated with that and they had to push through. So I think all those types of stigma that exist in the workplace, in the social, and different gender bias could also contribute to the fact that migraine being underdiagnosed, or there's a delayed diagnosis of migraine because of the stigma that exists.
Thank you, Dr. Chang, for your contribution. I think you've also answered the next question, and also I think Dr. Gerald, I've also touched something on this question. So I would just like for Dr. Sailor and Dr. Yilma, should you have any thought on this? Where do you see the misperception of what migraine is as a disease affecting people in their communities, home, work, and the medical system? Our panelists have shared that largely stigma may not be a something of a thing, but rather how people perceive migraine as a disease. So, where do you see this misperception common in your setting?
So, like I have said, the common misperception about migraine is it is labeled as just a headache. That is the major problem. And the accompanying symptoms, the disability that it produces, the effect it has on the daily quality of life, as well as even the productivity of a person is significantly affected because of those severe disability headaches. But those tend to be overlooked and they are sometimes labeled as, for example, being lazy. If you have any social events that you need to attend, missing them because of the headache that you're having will be labeled as being not being a social person. Okay, so it can be, for example, if you have a person who needs to be at work 5 days a week and they're missing 3-4 days because of the migraine attacks they're having, or even being requiring admission or injection medications, especially if the patients have investigations like a brain MRI that turns out to be normal, they will usually be labeled as something that's in their mind, more of a psychological problem rather than an actual complex neurologic problem. So at home, people who are who have the burden of caring for family members usually will be not capable of having this performing daily activities and not being on treatment, so they will be affected and they will be misperceived among their bosses, their colleagues, their partners, and so on. In the medical system, it is common to be misdiagnosed again, especially in primary health settings with the different disorders that we have mentioned before. And one thing I usually emphasize for patients who present, for example, just one headache at home, is to take a journal or to take a note so that we can see the pattern of the disease that they're having. Usually this will give a clue for the treatment, which we'll see later, but also it will help us in classifying on which category the patient fits in. So this is a common misperception I see from patients who have migraine headache.
Thank you, Dr. Yilma. And Dr. Sailor, any perspective you want to share on this?
I think just summarizing before that it really falls into two groups. There are the people who don't realize headaches are a disorder and have never tried any treatment and sort of suffer unnecessarily. And then there are the people who have severe headaches that are just misunderstood and they're sort of labeled as exaggerating or not wanting to work or their symptoms minimized both by their family at home, by their employers at work, and often in the healthcare system as well.
Thank you, Dr. Sailor. We'll be moving to the next theme, which is treatment, and we'll go around again to hear what options are available in different regions and what barriers also exist. So this time around, I think it will be okay to also start with Dr. Sailor. What treatment options are currently available to people with migraine in your country? And also what barriers to providing these options, such as patient attitude towards taking medication, cost, and availability?
Sure. So, unfortunately, we sort of have two different healthcare systems within Zambia, which I suspect is similar in the other countries represented, where we have the public system that really serves our most vulnerable patients, and then we have a private system that serves our more affluent patients. And in the public system, our options are pretty basic. So, we have, as far as acute abortive options, we have basic NSAIDs, we have paracetamol, we have aspirin, and that's about it. Some antiemetics as well. We don't really have triptans available in the public system. As far as prophylactic options, we're really limited to tricyclic, antidepressants like amitriptyline, some anti-seizure medicines, but other options can be really, really challenging. We don't have GPEDs or CGRP inhibitors even in the private sector. In the private sector, we do have triptans. We do have a wider availability of prophylactic medications. We do have a few providers, at least in the capital city, who can do Botox as well. But we are pretty limited with the newer therapeutic options, even for affluent patients in the private sector. And I think the major barrier is cost. And because cost is a barrier, then availability is a barrier because pharmacies aren't going to stock medicines that people don't buy.
Thank you, Dr. Saylor, for that insight. And Dr. Durao?
Well, treatment options here are not far from what she said. Of course, two categories of patients. We have the insurance scheme here, which does not offer so much to patients, just probably mainly abortive drugs like NSAIDs and other drugs that are not within the insurance scheme, and that poses a big challenge in the management of these patients. Fortunately for us, even though they have an insurance scheme, they can still access those medications. We can just prescribe them for them and they can go get them on their own. So a host of medications are actually available. For the aborting drugs, we have the NSAIDs available for us. Here we have the triptans available for us. But like I said, they are not covered by the insurance scheme. So triptans have to be gotten by the patients out of pockets. For the prophylaxis, of course, that is out of reach for a lot of the insurance scheme we have in the country. Just a few of them may be able to cover that. But in terms of medications available, we have a wide range from the anti-seizure medications to the tricyclic antidepressants and even to the monoclonal antibodies, which we've used. Just that a few patients, the affluent patients, can actually be able to afford this medication, and this serves as a big barrier. So cost remains a big challenge for managing patients with this medication. So that poses a problem but in terms of accessing care is really generally accessible, but it's just the cost of the medication. And sometimes when you want to do some investigations for them, it may also pose a challenge. Sometimes you need to do an MRI scan to exclude other secondary headache disorders. That also poses a challenge in managing patients. But overall, very few monoclonal antibodies, triptans are not available here. The monoclonal antibodies are available, Erenumab, for example. But most of the other medications are not available. Thank you.
Thank you, Dr. Durao, for the insight you've shared. Dr. Yilma, what is actually obtainable, or does this responses also resonate with what is obtainable in Rwanda? Thank you.
Okay, thank you. So Rwanda is quite different from my experience from Ethiopia. In Ethiopia, the same goes. So the private setting and the public setup has almost a different type of treatment, investigations. Medications are more available in the private setup, which is somehow even improving in the public center, especially in teaching hospitals who have a collaboration with international organizations tend to have a better improved care with availability of headache specialists and so on. But Rwanda, almost there is a universal insurance coverage where medications are available in the hospital. Even if they're not, patients can access medications from outside pharmacy. So for acute attack, NSAIDs, triptans are available, steroids are available for status migraines patients. For preventive therapy, antihypertensives are available, anti-seizure medication, gabapentin, pregabalin, sumatriptan are available, amitriptyline from the tricyclic antidepressants are there. I haven't seen patients who take CGRP and neuromodulation and so on are not commonly used. In Ethiopia, there are some centers that administer Botox injection for patients who have headache, but nerve blocks and so on are not. I haven't seen such practices. But here in Rwanda, there is a good insurance system where patients tend to have a coverage of majority of the medications that are available in the country.
Thank you, Dr. Yilma, for sharing the perspective from both Ethiopia and Rwanda. Dr. Chang, do you want to weigh in on the insights that our previous panelists have shared so far?
Sure. Just share the treatment options that are available to people with migraine in the U.S. include the over-the-counter medication like acetaminophen, NSAIDs, and combination medications. And then prescription medication, there are different anti-emetic treatment options. For triptans, there are currently 7 different triptans that are available, and including subcutaneous injection or nasal spray form. There are also Gepants for the acute treatment of migraine, such as ubrogepant, rimegepant, zavegepant, and lasmiditan. These are available for the acute treatment of migraine. As far as preventive medication, there are tricyclic antidepressants, anti-epileptic medication like topiramate, Depakote, or gabapentin, beta blocker, propranolol, metoprolol, and also 4 CGRP monoclonal antibodies, including 3 self-injectable medication, 1 IV infusion, as well as Botox injection. There are several neuromodulation devices available as well, and sometimes we would encourage patients to do behavior approaches such as biofeedback and cognitive behavior therapy. Despite these many treatment options being available, the treatment also really is critically based on patients' insurance plans. So a lot of these medications, especially the CGRP targeting therapies, are very expensive. And whether patients can receive those CGRP targeting therapy or even Botox injection really depends on their insurance plan. And there are certain barriers and requirements as well, like requiring patients to have tried and failed several oral medications before patients can get into these newer or more specific treatment options. So I would say that insurance coverage and cost would be a barrier for our patients to access those medications as well.
I have a question for the panelists, and that is, are behavioral modification used in any of these countries as a complement to the medications that are being used? Things like mindfulness, cognitive behavioral therapy, biofeedback, any of these therapies available?
I can speak for Zambia. We don't have anyone who does biofeedback, and mental health practitioners to do cognitive behavioral therapy are also really limited. And so those tend not to be mainstays because of difficulty accessing them.
So I haven't seen patients using this cognitive therapies and so on, but one of the psychiatrists were trying to incorporate mindfulness in the care of patients who have any type of chronic pain not responding to the general treatment options, but that's not a common practice to be seen in most countries.
Well, in Nigeria, it's not a very common practice, but we advise patients to probably avoid triggers, and then they could do that on their own, probably access those things on online, but as a general practice for CBT, no.
Yeah, I guess a follow-up question is just whether the electronic applications which are available would be useful in your setting. Would people be open-minded to this, or would they need to be educated about trying to control their feelings as well as taking medication?
I think smartphone apps are certainly accessible in Zambia. Even people in remote areas now often have smartphones. And honestly, I find internet accessibility better in remote areas of Zambia than in much of the United States. But there is definitely a huge stigma about mental health disorders. And so suggesting kind of counseling and things that might be associated with mental health disorders, I think would be a barrier for a lot of patients as well.
Dr. Gerald, do you want to respond to Dr. Godley's last question? Or Dr.
I already mentioned that we could advise them to check on some of the things online. The only challenge with that is we don't know the authenticity, the quality of what is being offered. A challenge, we need to regulate some of the content, because a lot of things online that may not be very helpful to the patient. That's just my comment on that. But we may need to look at what they're going to look at to see whether they're actually going to be useful, so they don't get more from even looking at the things online.
Okay, thank you. Dr. Hilma, any response before we move to the next?
So the whole point is whether we are able to provide them with this online services and so on, and also give them a bridge to the cognitive therapists and behavioral therapists as well. So for the setting and I'm working at, we can offer such options for patients, and we can even collaborate with the psychiatry department. But like it has been mentioned, mental health disorders or collaborating merging the two disorders and treating them, that there is a potential for patients to have other concomitant psychiatric disorders might face some resistance, but it's possible to do, and it's one of the things we can consider as well.
Thank you, Dr. Yilma. So moving to the Dr. Godley.
I'm going to point out that we really have our last 5 minutes, and I think we've covered many of the issues in this last treatment question. So I would ask the panelists in the final round here, if there was one thing that you could recommend focusing for improving treatment of migraine patients in your setting that's practical, because obviously we'd love to have more neurologists, we'd love to have more money, but living within your low resource setting, it would give great guidance for us if you could identify things you think that are doable in the immediate future that would help patients.
So the short-term thing could be incorporating patients into the treatment plan, especially advising patients to have a good headache journal if they are coming from rural areas, help in identifying whether treatment is effective for patients or not, and having maybe a standardized format where we can use at different setups is one thing. The second thing is giving short courses for primary healthcare providers that will help in identifying patients who have migraine headache from the primary health setting, so that there will be a good referral system throughout the course of the health system. One thing that is good and that can be launched in different places in rural areas is having trained neurologic nurses, where they can have basic training, for example, in common diseases like migraine headache, seizures, and so on, where they can treat patients and then refer them back. Like I said, shortage of neurologists is not something that can be solved in a short period of time, but having recurrent trainings on the updates on this topic would be helpful in treating patients.
Okay, so my take-home message would be that just education is very, very key. Radio programs and seminars like this, lectures, getting people to understand that all headaches for our own setting, all headaches are not malaria or enteric, because we have malaria endemicity here. So we need to understand and train and teach people that all headaches are not malaria. That's very, very key. And that's a very, very key thing to barrier to care for patients. And having done that, I think most of the pressure will have been reduced, and misdiagnosis and access to care will be better if we also train our other healthcare providers on identifying these headache subtypes and then be able to refer to us for further care. Thank you.
I also agree. I think reaching for GPANs and CGRP inhibitors and neuromodulation is very aspirational at this point, but also would benefit a much smaller number of patients than just making sure we provide accurate diagnosis and basic treatment that will help the majority of patients. And I really like the Global Campaign Against Headache, which is this UK-based organization led by Tim Steiner has proposed this 3-tier model for headache care that really suggests that 80% of patients with headache can be adequately managed at the primary healthcare level, as long as we provide basic healthcare education to those providers. And so I think that's the lowest hanging fruit, is really just to make sure that all healthcare providers in the primary healthcare system have access to basic headache education, how to recognize dangerous headaches, and then how to treat kind of primary headaches, at least as first line. And if we improve that, I think we would improve the lives of a lot of our patients. And just some basic, public awareness campaigns so that people realize that headaches are not normal, and they are a disorder that are treatable and can actually seek care. I think those two things would have a major impact on our patients with headaches.
Thank you for those comments. I'd be curious how many people have seen the Shades for Migraine, which is an effort to raise awareness using just sunglasses as a symbol for migraine. Has that crossed anyone's consciousness? And Tim Steiner is somebody who I also know well, and I'm sure Olorunda and I and others trying to help in this area will lean on him. He's had a lot of experience.
Okay, thank you, Dr. Godley, for sharing those. I think this part of the question has been responded to, and this question will be tailored only to Dr. Saylor and Dr. Chang, just to share, because Dr. Saylor also have experience working in the United States. So what similarities or difference in how migraine is understood and managed in Sub-Saharan Africa compared to the United States? I know responses have been shared earlier, but you can just summarize and bring this, just bring this home for us. Thank you. I think we should start with Dr. Chang.
Yes, I think we have discussed in the previous question that there are a lot more medication treatment options in the US. However, it's still limited to the cost and insurance coverage to be the main barrier of patients accessing those medications in the US. However, there are a lot more treatment options, especially for people who could afford that. But I just want to go back to address to the previous question on, like how we could raise public awareness. And I think raising public awareness is very important, as many of the panelists have discussed. And one thing is to provide education, especially for non-neurologists, primary care, internal medicine doctor, and also like having public campaign toward patients, so that patients felt that they were heard and they are validated, and reducing stigma. That is very important as well. And I think going forward, there are several things that also could be used, especially many panelists mentioned the digital technique and smartphone that might be available. So doing campaigns through social media, or even utilizing telehealth, or even in the future incorporating some of these AI techniques as decision support tool could potentially help to raise public awareness and provide early diagnosis and treatment for migraine, even if the medications are limited, but patients are aware of that and clinicians are able to diagnose them earlier. I think those are all helpful approaches for patients in different regions.
Thanks. I think that's really helpful. In my experience, when I was practicing in the US, the patients who actually made it to a neurology clinic had already had trials of several medications and were often the more refractory migraine patients. Whereas in Zambia, we're often seeing patients who are getting to us without ever being tried on even in simple painkillers. And so the level of complexity of the average patient with headaches who makes it to a neurologist in the United States is much higher than those that kind of by happenstance make it to a neurologist in Zambia. And so in many ways, it's a bit easier to manage these patients in Zambia, even with limited resources, just because you have the full armamentarium of things to try, and they often get a lot of relief from those first line treatments that you often don't see by the time they've reached you in a specialty clinic in the US.
Oh, thank you for that insight. I think that's a relief that even from the first line patient gets quality relief. So now we're moving to another theme, public awareness and education. And from the last conversations, this actually came big, which is actually recommended education and awareness. But what we want to confirm from this is, have there been any local or national efforts up until now, such as public educations, campaigns, or grassroots initiatives to raise awareness about migraine in your country? What format or approaches were effective or not, and why? So, Dr. Saylor, I think you can also start with us. Then we can also go around the other panelists. Thank you.
Thanks. We have not done this in Zambia yet. We just started really the field of neurology in Zambia about 7 years ago, and we've done some epilepsy, some dementia, some MS, some stroke work. We haven't made our way to headache just yet. But we found that media outreach for other neurologic disorders, media outreach, like lots of radio and TV interviews, can be really effective ways. And then even just standing out front of the hospital and handing out flyers or pens or things to get people's attention can be helpful as well.
We'll move to the next. Policy, access, and health system. What data on migraine exists? What data exists on migraine in your country in terms of prevalence, burden, and access to care? And how has this data or lack of it influenced health planning, policy, or funded decision? So I think we can start with Dr. Gerald.
Okay, good. Like most of African speakers who attest to, data is a big challenge in this part of the world. So most of the times, the data will have hospital-based data or very small community-based data, which are extrapolated. The migraine prevalence in Nigeria is about 15 to 20%. Some studies quote 16, 15, but at the average, 20% of headache patients. So again, done within the headache community, not as a total community, as the total disease body. It's looked at in the head and in the context of headache. So when we look at headache patients who presented, and many of them had migraine, and so that's how it is admitted, generally speaking. So I'll put it at about 15 and 20%. And this lack of data becomes a big challenge because when we don't patients really have migraine, but just it's very difficult to plan really without data. So, but in terms of funding, like I said, the insurance schemes just cover the abortive drugs. Really, just a few prevention drugs are covered by the health body, and so therefore, some of these policies probably because of the lack of data are not driving policymakers to include take migraine very seriously. Thank you.
Thank you, Dr. Gerald. Dr. Yilma.
So there is the prevalence and incidence of migraine headache. There are no large population-based studies, but there are reports from hospitals, outpatient clinic, inpatients, and also some studies done in like specific areas like in factories and so on to assess primary headache prevalence, including migraine. One that I got from Rwanda is one of the teaching hospitals, the 22% of the patients' outpatient visit reasons were headache, and among this 8% were for migraine. Other studies done in some factories back in Ethiopia showed that the migraine headache prevalence can be as high as 14%. But like there is lack of data, but the reports from different centers show that it is almost the first or the second leading cause of outpatient department visits, like as a general primary headache, and migraine headache accounts for a large proportion of the patients.
Thank you, Dr. Hilma. Dr. Saylor.
So in Zambia, we benefited again from Professor Steiner's work. He had conducted a population-based study both on the prevalence as well as the burden of primary headache disorders in Zambia that showed there's about a 23% prevalence of migraine adjusted for age, sex, and location, meaning urban versus rural, about a 23% prevalence of tension type headache, and somewhere around 10 to 15% prevalence of chronic headache, much of which is probable medication overuse headache. And so there are actually good data in Zambia at a national level on the prevalence and the burden. And he showed just the huge percent of gross domestic product each year that's lost because of people unable to do work. It's somewhere around 3% of national GDP is lost, likely due to headaches itself. And so, I think that this are there. I'm not sure that at this point we have really leveraged it with the Ministry of Health to try to get policy or health planning programs in place. We have not yet, as we've trained neurologists in Zambia, we've trained people with interest in epilepsy and stroke and movement disorders and things, but we have yet to find our headache champion. And so once we find a headache champion, then I think that they have the data they need to take this forward and try to influence policy based on those data.
Thank you, Dr. Saylor, for sharing those insights with us. And Dr. Chiang, you want to share any perspective on this?
Yes, in terms of in the U.S., migraine affects about 16% of people in the U.S., about 21% in women and 11% in men. Roughly about 39 million people in the U.S. have migraine. Especially migraine affect people that are at the work age, people aged between 15 to 49 years old at the age when they have to work and have productivity. People also reported that there have been 4 million emergency room visits in the U.S. for migraine, so that is a lot. And also migraine is the second leading cause of years lived with disability globally. So I think these are all very important numbers that really highlight the high prevalence and disability that associate with migraine. Also, there are data on people being undertreated. So, for example, among those who are eligible for migraine preventive therapy, only 17% have received preventive medications. And similarly, only a small percent of patients with migraine had ever received a triptan. So I think, these data is highlighting the high prevalence, burden, and access to care to migraine medications are important in that people and different advocacy group have really used this data to advocate, for example, on Headache on the Hill event, to raise and increase research funding support from government and other funding agencies to the study of headache disorders.
I'll just add one other statistic that I always find intriguing, and that is that when we say that 12% of the population is affected by migraine at any one time. In contrast, there was a study that found 43% of women were affected by migraine sometime during their life. So migraine being a very changeable disease, fluctuating throughout life, there is actually, this affects women particularly at a very high rate, maybe as many as 40% of women. And this often bears out if one has a group of friends together and asking about migraine, how often you'll find that people have had either active or a history of migraine. It's incredibly common.
Thank you, Dr. Goli, for that extra layer of insights. Last on policy access and health system. At this point, if you have any question, please let's do well to use the Q&A box so we'll get to them after the panel discussion. So how can African neurologists, other healthcare professionals, advocates, and researchers participate in the future of migraine and headache disorder innovation, whether through clinical trials, academic exchange, or policy advocacy? Dr. Yilma, do you want to go first on this?
So, seeing the number of patients and how they suffer, neurologists working in Africa are at the center of these treatments, and the gaps that are seen, the challenges that we see are there. So even if majority of the migraine headaches can be treated with common preventive therapies that are available, there should be a room for innovative measures, plus reaching the population and doing like majority of us like a population-based studies and population-based studies, and also sometimes even after we complete that, usually our training advances in each disorder would be lacking. So being part of academic exchange programs and also communicating with the appropriate officials for an advocacy is very important. There are different international groups like International Headache Society and so on, which we can take part in, and also maybe attending and international conferences with good networking with headache subspecialists and experts in that area would be a very good approach in advancing the care. And delivering data is very important. Usually policymakers would like to see numbers. How is it affecting the nation? What is the cost that we're going to face? How are we going to proceed? And so on are common questions provided and questioned by them. So being part of the data, being part of a good network and encouraging an interaction with experts, and also encouraging our residents and students to be part of the headache societies is important.
Thank you, Dr. Yilma. Dr. Saylor?
Yeah, I think two things. I think that education is so important, and real capacity building makes long-term change. And so I think that is really important. I do think that as physicians in general, we are often not great at advocacy, and so really empowering ourselves with more advocacy skills to use the data that we have to affect change at a national level is important. And then I also think that, many disorders manifest or are perceived or expressed differently in different cultures. And so I think that getting more primary data from the continent on the symptoms that our patients describe, on the impact of these disorders here are important for all of these things, for education, for advocacy, and for all the efforts we have to improve care of patients with migraine.
I just would make a short comment in that I've been involved in creating a patient-reported registry in which we're trying to track a lot of different symptoms than just headaches, as well as the response to a range of treatment options. And I would, so far our IRB covers up the United States, but if there were anyone who was interested in their particular country in using this tool, they should contact me and see if it's called the HEADS registry, if one wanted to Google that, but that could be a useful tool.
Thank you, Dr. Godley. Dr. Durao?
In addition to what has already been said, I don't want to repeat what has already been said. Of course, there are a lot of things that can still be done in Africa. The basic problem is probably funding of some of these research and advocacy. I think that's the bedrock of the challenge. But I still think that exchange programs can help a lot. Exchange programs can help in enlightening people, in improving the healthcare system in this environment. And with some of these things that are online now, where the exchange programs can be done online, but in terms of clinical trials and database, that is still also a big challenge for researchers here. Because of course, like I said, funding is a big problem here. So most of the data are hospital-based data or small studies which are being used or extrapolated to cover the entire country. So in terms of for in terms of the health system for African neurologists, I think one of the major things is trying to collaborate and see if we can collaborate with partners to get funding to carry out some of these researches, advocacy, and research. Thank you.
Dr. Chang?
Yes, I would just add that I think there are several, I think participating in international societies like the International Headache Society, the American Headache Society, or Association of Migraine Disorder is quite important, because a lot of times there are efforts from neurologists or the society members. They want to collaborate with neurologists across different continents, including Africa, on this global research for headache care. So I think encouraging more and more clinicians to participate in those societies and build connections with other colleagues around the world would really be helpful in terms of advocacy or facilitating research, patient education, and also exchange of different, for example, online resources that might be available, and also experiences. So I think I would just add that participating in those international headache societies can be quite helpful.
I'll also make a plug for the migraine outreach website that Olorunde is developing. I think he is trying to curate a lot of these resources and be a reliable source of where one could find educational and research tools, as well as other activities that would be educational.
Thank you, Dr. Godley, for adding that. And migraine outreach was actually started to actually bridge the gap with migraine education, awareness, and also advocacy in sub-Saharan Africa, which is why we're also here today. Okay, so we'll be taking this last question, and should you have any question, please, from the audience and participants, kindly use the Q&A box. We'll be taking them after this response from our panelists. And in earlier conversations, some of these responses have been attended to, so we'll just take it as a way of the panelists closing the discussion with more ideas than what they've shared earlier. So what innovative ideas or approaches do you think could make a meaningful difference in reducing the burden of care in your region? Dr. Saylor, I think you may want to go this round.
Sure, I'll go first, and then unfortunately I'm actually on call and to run and see a patient, so I'm going to have to sign off. But we found a lot of success with webinars that reach a large number of healthcare professionals across the region to build capacity. And so I think that these types of opportunities are really, really important in increasing education and awareness. I think I've seen in the MS field, which is one of my interests, we've seen engagement with international organizations who have provided advocacy training and support in organizing patient support groups. And then together, the healthcare workers and the patients have worked together in advocacy strategies with the ministries of health at a national level. And so I think that would be another potential route to really make a difference from a policy level well. And then, creative education outreaches to the public, I think, are important too, whether it's in storytelling and videos and migraines. I think getting a local musician or someone who has headaches that can really speak to this in a public way and raise awareness is always an effective strategy as well. So I think those are my thoughts. I'm sorry to run early. Thanks to all the attendees and co-panelists, and to Olorunde and Dr. Godley, and best of luck in the rest of the webinar.
Thank you, Dr. Saylor, for joining today. I think your perspective actually added color to the conversation. Thank you, and enjoy the rest of the meeting. All right, so Dr. Yilma.
Okay, so one thing I see is, because now social media is on the rise, using social media and different platforms, using different influential doctors, famous individuals, celebrities, and so on, who have an interest in this disorder, as well as who have been affected by this disease, as being a center or a representative of this disease is very important. Engaging with, like I've said, international societies with experts in headache, who have long and extensive experience on this disorder, and making them accessible to majority of the healthcare providers through either recorded webinars, and also creating a national patient society with headache disorder will have an influence in policymakers, and will also help in identifying what solutions we can come up with that can be doable in setup. So overall use of social media, national television, radio programs that are usually well reaching among the society, plus sometimes even having some like small discussions with not health professionals only, maybe high students and so on, so that they have a knowledge of what's going on, so that they can educate their family members and so on, would be a good approach to reducing the burden of the disease. Yeah.
Thank you, Dr. Yilma. Dr. Gerald?
Yeah, well,
and Dr. Chan can go.
Okay, good. Well, there are a lot of things that can still be done in reducing the burden of migraine in our regions. Like Dr. Yilma already said, social media is a very good platform. I have developed personally something that I share with a lot of my patients, which are the headache triggers. It has helped me a long way to manage such patients, and I've used it for most of the time when I have contact with migraine nurse. It's something I developed from my own, from being a migraine myself, and then from other studies or other works. The triggers generally, so I send it to my patients and I said, look, if you do this, it will help in reducing the burden of your headache. So some of these kind of things can help really, especially when patients pay a lot of attention to triggers. It helps for us who are migraine. Triggers are a very, very big issue. Sometimes the triggers are unavoidable because sometimes work pressure and some things are beyond us, and so we need to do some of those things and get them done. So meeting targets can be a problem. So as a migraine, you must look for a way to work around stress, generally speaking. And so when some of this information are shared with patients, creating awareness, it will also reduce the disease burden, and that can be shared in social media, and patients can benefit from that. In addition, there are various pressure groups which are also which have been formed. Like, for example, we have the Nigerian Headache Society, which its main role is to advocate and to further educate people about creating awareness of different types of headaches, even other than migraine. There are various types of headache, and not all headaches probably are febrile illnesses like malaria and enteric fever. So these are all platforms that have been used, and of course our parent body sometimes when we host our regional conferences for our NSNS, we share some of the themes of some of these conferences are maybe headache, and in that case it creates a lot of enlightenment for the society. But overall, one of the most useful tools that we cannot take away is social media. And so I will really advocate that some of these things are put out there and people access it, in social media. I'm not sure what I did on my phone, and suddenly I started getting some messages on this webinar. Oh, congratulations, what's going on? I'm not sure what I touched, but I think the thing went into my page in the, I'm not sure what it is that happened, but somebody helped me undo it. So a lot of people just started responding and say, oh, what's going on? So I think social media is a very, very, very good tool in our current generation that can help us, especially in resource-limited countries like ours, where we have limitations.
As a closing question, I think emphasizing on the forward thinking and innovative ideas, I would say that leveraging novel digital tools such as artificial intelligence and really create accessible and affordable AI tools using as a clinical decision support system that can help clinicians diagnose headache disorders early, improve the accuracy of headache diagnosis, and even help patients generate or design a personalized treatment plans. I think those will be the next step in the headache field. And then bringing those AI tools to different regions, including the underserved areas, could be really helpful to help patients get diagnosed with headache earlier, get treated earlier, and to have a more personalized treatment plans. So I think that applies not only to the US and also globally. And that is, I think, and I foresee what can make a really meaningful difference in reducing the burden of migraine in different areas in the world in the next 10 years.
Thank you to all our panelists for the thoughtful and for the thoughtful insight you've shared with us this evening. Just to add to what our panelists have shared with regards to forward thinking, at Migraine Outreach, we launched a program called Migraine Voices Africa, which uses lived experience of individuals with migraine to for as a tool of migraine education and awareness, and it will be held on all socials and also on our website migraineoutreach.org in the next 2 weeks. So to all the participants on this call, you're going to get an email to that notification, and also you can also follow Migraine Outreach on all socials, LinkedIn, Facebook, Instagram, and on Migraine Outreach, and also the website is migraineoutreach.org. This brings us to the end of today's webinar. I want to say a special thank you to our panelists, Dr. Yuma, Dr. Saylor, Dr. Chiang, Dr. Gerald, for your time, for the insights you've shared with us, and actionable steps going forward. The recordings of today's webinar will be made available and will be on our website and at www.migraineoutreach.org, and also be sent out to all attendees. I don't know if Dr. Golly have any closing reflection as we end the webinar.
No, I just think it was so interesting to hear from each of the panelists, and I think that we've all really been able to take something from this experience. So thank you very much for your time.